Good afternoon. My name is Shannon Steen. I am proud to serve as the Executive Director of Good Shepherd Housing and Family Services. I am also proud to be an alumni of George Mason School of Public Policy. So it's nice to be back. Day in, day out, I see homelessness from the lens of a service provider. We have a mission of reducing homelessness, increasing the community support, and promoting self-sufficiency. We operate in southeastern Fairfax County, which is just down by George Washington's Mount Vernon. Fairfax County, just as a thumbnail for you all that may not know, about 400 square miles, about 1.1 million people, and on any given point in time, there's about 1,500 homeless people in our community. Good Shepherd Housing and Family Services, our reach is to about 1,500 of those individuals throughout a year. So that's what I see on a regular basis. I'm very excited to have a multifaceted panel here. We're going to get a couple different slices and looks at things, but first I would like to introduce Dr. Virginia Beard. So please.
Thank you. Good afternoon. I'm going to start with a little background on where this project came from, because it gives you an idea of where my students and I are working on this. So about 3 years ago, I'm a professor at Hope College in Holland, Michigan, which is a small faith-based liberal arts school, and I worked with the local homeless shelter, the Holland Rescue Mission, on a project with my public policy class, which was a really good idea in theory and a lot of extra work for me and the students in practice, but it resulted in a paper that was published with the students who served as sort of an ad hoc evaluation team, interviewing service providers, practitioners, policymakers, and members of the homeless community about an issue that a lot of the service providers in Holland were dealing with that they called the gap population. So members of the homeless community who experienced chronic homelessness on a cyclical basis, who were too high functioning to qualify for a lot of the services and policies and money that were available, but too low functioning to maintain stable housing, employment, etc. As I went through this and worked with a lot of the local service providers, West Michigan, if you're not familiar with it, is a very faith-oriented place with lots of churches and lots of ethos of do-gooderism, right? So there's a lot of support for trying to solve this problem as we got the information out. The Holland Rescue Mission is a faith-based, non-governmental organization. And so as we went through trying to figure out what are the causes and what are ways that we can better meet the needs of the gap population, it seemed that there was this certain ethos or vein of understanding behind why people were experiencing homelessness and how to help them. That, alongside with a lot of the theoretical reading I was having my students and I do together, and with some of a different branch of Hope College took over after our project was completed to try to meet the needs of the gap population once we had defined who they were and what were some of the special circumstances and common themes across these individuals' lives. And what resulted is a partnership both with some policymakers, NGO service providers, and local churches to do sort of wraparound services and help people at an individual level. And it's been really successful. There's a house that has former members of this population living in it. It still seemed like there was some assumptions behind the kinds of questions that the service providers were asking in my community and the kinds of solutions that they were necessarily seeing as what needed to happen, how they helped people not stay homeless. So the next step that I did was with one of my student researchers, we decided to step back and take the theoretical academic approach and say, okay, is there some broader part of understanding policy and homelessness that what we're seeing in West Michigan fits into? And so we decided to do some theory testing using two of the main theoretical bodies in the public policy literature, punctuated equilibrium theory and advocacy coalitions framework, to see which of these helped explain some of the federal and local trends on homelessness. And would that help us have a better understanding of why service providers down at the grassroots level were responding the way they were? So is their mindset being primed by this larger picture? And so this paper fits in that, looking at the federal level, and then we've done a second paper where we're starting to add case studies looking at New York, Pennsylvania, Colorado, California, Michigan necessarily, because that's where we are, to try to see how this plays out in different contexts given the history. So what this paper does is it originally started in the 1980s with the McKinney-Vento Homeless Assistance Act, and was going to be sort of a thick description looking at the federal response to homelessness and how it emerged. It ended up starting in the late 1800s as far as the historical events that are included. Because as I started backtracking, it's kind of interesting to follow the first presentation that we had. The role of the progressive era became very important and where that came from. In the late 1800s was the first federal census of former slave dwellings. So that was the very first sort of that I have been able to find thus far, federal response to any kind of issue dealing with housing. What we found as we looked at this, as far as theoretical fit, it's a conglomeration of the two theories that best help explain, we think, the federal response. But the more interesting finding for me that I think fits to our first talk, so I'm going to focus on that, is the mindset. So these two theories both talk about the national ideology or the national idea behind the factors that policies are trying to solve. And so in the case of housing and homelessness, during the progressive era forward into FDR and the workforce creation that he did, there was a basic national narrative that said, you're homeless, you're struggling with poverty, you're unemployed, and there are structural institutional issues behind that. So all the federal programs that were created were on the idea that it's just lack of opportunity, there are structures in your way, and we're gonna help fix those structures. Then into the 70s with a number of the historical events that we've traced from wars, the Yom Kippur Wars and the OPEC raising of gas prices through the embargo, thank you, is the word I was looking for, the embargo, and the creation of the United Nations fitting into that. So sort of building off of that into the 70s, the national ideology, mindset, understanding of why people were poor and why people were homeless was changing, right? Some of it was a pushback against some of the social grassroots movements that came out of the Vietnam War, others with the rise of HIV/AIDS, and a lot of this led to the election of the Reagan administration. So I don't fully find and put on the back of Reagan and the Reagan administration to blame for the change in national ideology. Some of that changed, and that's how he and his people were elected. But definitely his administration took that, to use current language, as a mandate to change a lot of things, right? And so from the 80s forward, the national ideology, although there were advocacy groups pushing back against this along the way, just like there were advocacy groups from the progressive era forward saying, no, there are different causes for poverty and homelessness. But from the 80s forward, the mindset has been you're poor, you're homeless, you're unemployed, and there's something about you that's causing that. So the policies that have been created, and this hasn't changed at the federal level, regardless of who the executive has been, right? So Reagan, Bush, Clinton didn't do anything much different from his predecessors on housing, homelessness, poverty policy. The ideology remained the same. And so the policies that are happening at the national level, even some of the reauthorizations of the McKinney-Vento Act post-87, all had this mindset that you're poor, you're homeless, you're unemployed, and so you need retraining or drug therapy or you've made bad choices. So the policies and the funding streams that exist all coalesced around that. Right? The most recent reauthorizations and some of the dialogue under the Obama administration have shown a potential change in focus on that, right? And so looking at the theories, I haven't even progressed the slides. There's some fabulously beautiful information in my PowerPoint presentation, and I'm happy to share it with you. I do this when I teach too. I end up using 2 or 3 of the slides that I create. There's been some potential changing under the Obama administration. And so when we talk about the theories, the punctuated equilibrium theory is the idea that policy change tends to happen in stasis, especially if the ideology remains the same. And there can be some punctuating event, either a change in mindset, usually the coalescence of a change in mindset in some major event. And for those of you who aren't familiar with PET, for my students, I use the example of 9/11. Right before 9/11, we didn't hear things like War on Terror or Homeland Security Act, etc. We had this major punctuating event. It opened the window of space for policy change, and we had a change in ideology of what was important that we needed to focus on. And since then, things have settled back into kind of a stasis with a whole new set of policies and focuses around terror and security. The same kind of thing around housing and homelessness from the progressive era to Reagan, and from Reagan to now. We're seeing the possibility, because of some of the fallout of the 2008 economic crisis, because of some of the things that have already been mentioned with the persistence of poverty and homelessness and health issues, the executive level, actually with some advocacy groups that are continuing to push against this mindset that you're poor and homeless and unemployed and it's your fault. There does seem to be some change potentially happening and some cracking of that as the national ideology and national conversation that could lead to some change, some, either a slight punctuation or potentially a major one given the 2008, the bankruptcy, the fallout, the persistent problems with housing. And so that's where we stand right now, looking at the federal response to housing and homelessness with some really interesting events that have happened at the state levels, especially in New York, which my student did all of the case studies that have been done thus far, and she couldn't be here. She could explain them quite beautifully, but seeing how those are feeding into the federal picture and being affected and constrained, even if you have some leaders at the state level saying, no, we don't really see this as the picture in our communities, they're within the framework. And so going back, and I'll finish with this, to the situation in West Michigan, what I was sensing and seeing was this ideology that's saying, you're poor and you're homeless and it's your fault. And even loving, compassionate, empathetic organizations not realizing that this is an assumption that's only about 25 or 30 years old, that are making the policies and programs to try to help the members, in our case, of the gap population, as they're terming it, based on this idea that, no, it's not structurally that there's not enough housing, et cetera, but it has to do with, well, you use drugs, or you don't have an education, et cetera, and so those are the responses that are being made. Right? And so our hope is to be able to use this and build a number of really strong case studies to say, maybe we in West Michigan can think differently, because luckily the guy who's the head of the Holland Rescue Mission is really open to these kind of conversations. We don't agree on everything, but we have really good conversations about what data, evidence, theory, how academic and practice can work together. So our hope is to bring this to our local community and say, maybe we can rethink about this in a way that's not Republican, Democrat. We're not going to get into those debates, but that we can say, let's look at the structural institutional issues in West Michigan and not just the individual level factors. So those are our findings and kind of where my goal as an academic / practitioner in housing and homelessness fits.
Thank you, Virginia. While we're doing the transition here, let me just welcome Dr. Kim Bullock down. She's going to get set up in just a minute. She's going to give us a look at, from her perspective, working with medical students, what some of that service learning looks like. We're getting 3 interesting snapshots on the topic of the day, and my hope is that we can tease out some linkages among them as we get going.
Hello, I'm Dr. Kim Bullock, and I'm actually an emergency physician, family physician, not too far removed from where all of you are in terms of training and struggling with all of the sort of practical pieces and translation of policy into practice. And I actually worked in a very small area of Oklahoma called Broken Arrow before I came here to Georgetown, and found that a lot of the issues addressing folks who I would call on the edge, at risk, as well as those who are homeless, both on the Indian reservation where I served as a physician, as well as those in my practice here in Washington, D.C., shared some very, very similar principles. I also focused a little bit on the subpopulation of folks who are very high incidence of homeless, and that's domestic violence, women and men on the Indian reservation. My points today will not address my experience in working in those populations, but simply to just introduce the fact, as I think has already been previously stated, that there's some really universalities to the discussion and to the narrative, regardless of where you practice, regardless of where you are. Not a surprise, but certainly a surprise to me coming from Oklahoma and then coming to Washington, D.C., and seeing some of the same challenges, some of the same issues. There are cultural nuances, of course, that distinguish working in Broken Arrow as opposed to Northeast DC, but some of the same human struggles and condition are very relevant. And taking that experience and applying that to teaching within the framework of service learning was extremely exciting, because service learning inherently brings that sense of humanness and human quality to the practice of any discipline. it takes you out of the didactics or out of the environment of teaching in the classroom into the, what I call living laboratory of the environment, of where people actually live and breathe and work. So this is some of the students that actually have worked in one of our homeless shelter areas. We have about 5 areas in DC who work, community-based organizations who work with the homeless families, both individuals as well as families and those who are at risk. We've been working in this particular environment with these 5 organizations for probably about 7 or 8 years. Service Learning has been around at Georgetown for probably 20 years, and we were one of the initial sites that actually was reviewed by the Pew Commission, which looked at service learning as a tool for learning about communities within the construct of medical school. And their premise was that service learning is indeed the perfect sort of environment to create that learning process about human interactions. And what is service learning? There's 3 components to this. It's mission-based in terms of mindfulness to people and humanity, and for Georgetown, it is the term cura personalis, which is care of the whole person. It integrates with cultural competency, and we all have our own nuance and understanding of what does cultural competency mean. I think we're sort of past that term in a way, because there's not a sense of what defines how you are competent, but how you develop in your own proficiency within the arena that you're practicing in helps to define whether you in fact are proficient in addressing cultures across spaces and time. And then the experiential learning is actually the crux or the core of what service learning gives to the student in terms of addressing this, whatever topic it is, and in this case, it's learning how to practice and have a greater appreciation of the homeless within the healthcare context. And then why use service learning? It is because it takes you out of the classroom and into the environment of learning, which is the living laboratory. Homeless individuals face barriers, and this is one of the emphasis that we give to students, because many of them come from around the country and they sense that homeless folks, as was mentioned before, it is part of their own construct. They got there by themselves, made wrong choices. But indeed, they need to look outside of that paradigm and see that there are indeed structural barriers, social determinants of health that factor into this, dealing with housing, poor transportation, access to care, that certainly are part of the problem. Coordination of care or lack thereof, certainly we've addressed a little bit in terms of access. Access is a huge problem, whether, again, you're in Broken Arrow, Oklahoma, or whether you're in Northeast or Southeast Washington, D.C., or in areas of Arlington, Fairfax, Virginia. Coordination of care is a big piece. Lack of awareness of the different, what I call moving parts involved in caring for homeless patients, and I will mention that that moving part is part of what I call systems of care. There's multiple systems that are involved in caring for not essentially the homeless population, but all populations. There are moving components to systems of care. There's a complexity that all of us have experienced if any of us in this room have been patients. There's a tremendous complexity that deals with systems of care. Lack of the understanding of those interrelated systems, specialty systems, primary care, subspecialty systems, allied health, paraprofessionals, navigators, all of those aspects of the care system. Marginalization, a very central component of a barrier to care for the homeless population that we serve. Negative stereotypes, personal biases that we as providers, wherever our setting is and whomever we are in terms of our professional state, bring personal biases to the table. Providers, again, may not have the cultural sensitivity, awareness to address the particular population, and again, that coming from their own inherent biases and stereotype. Limited interaction or exposure with the homeless population. And again, at Georgetown, we have a large population of students who come from very small towns where the homeless population may in fact be so segregated, so marginalized, and as I say, silent, that they don't even exist on their street corners. Health needs, we focus a lot on these particular areas as a way of didactic introduction to the students before they go into the community. Did that kind of quickly, looking at both the characterization of the population, the categorization of both chronic and acute disease management, emergency departments, safety nets as part of the safety net for care, utilization of health resources. Again, that it discusses that whole systemic or systematic approach to care, which is so critical for the students to learn about. And then modes of practice. For most individuals, the interface is with community health centers or federally qualified health centers. And as was mentioned, certainly within the Obama administration, there's been a groundswell and a focus on community health centers as a provision for the safety net for, again, not just homeless, but all of us who conceivably would have need for more of a public service rather than a private practice type service. Service learning as a mechanism for teaching compassionate care, because again, it takes students out into the community. What this is basically identifying is that there are systems both that the students bring with them as part of their cadre, and the community-based organizations that they and patients interface with have their own sort of systemic or systems, if you will, that they bring to the table: social, environmental, legal, and cultural. And part of our work is to help the students work through all of these different systems and how they interface. Systems thinking in action, from a sort of systems perspective, these are all of the different pieces that we help the students engage in learning about. There's the legal human rights component, health systems itself, doctors and hospitals, built environment, learning about the different types of environments, of poverty, food deserts, resource-poor communities, and what impact that has in terms of barriers to care, and then the social systems that impact, such as education or lack thereof, families and communities. And we look at families and communities, we look at them from a perspective of strength or assets rather than poverty and need. Although there are indeed needs and poverty components that need to be addressed, most of the students see poverty as the central theme. They don't see the assets that our homeless population does bring to the table, the assets that they do have. And one of the outcomes from our program is that the students develop a realization that indeed there's a true resiliency to families that are homeless that enable them to more than survive but thrive within all of these different barriers that they encounter through the system. These are the 4 places there that the students participate in: Father McKenna Center, Georgetown Ministry Center, Mount Carmel House, and Tenant Empowerment Network in DC. And all of them focus on different aspects of the population so that the students don't see homelessness as sort of a monolithic group, but they see that, for example, at Father McKenna's Center, there are individuals there who were very successful politicians, very successful within their sphere of influence, very successful teachers, educators. At the Georgetown Ministry Center and at Mount Carmel House, the students encounter some very successful women who've done a lot as community organizers, as educators, leaders, and this is truly an epiphany for some of the students to realize that there is a whole strata of successful and potential within the homeless community that they are completely unaware of or sensitive about. The Tenant Empowerment Network, some of you may be familiar with this particular type of networking organization that helps to empower residents within communities, and we have some students that have actually sort of integrated themselves within some of the networks after they have completed the service learning experience. These 2 books we have given them as references for their initial journey, and some of you may be familiar with them. David Hilfiker was actually a physician who worked with one of our physicians in Washington, D.C., Dr. Janelle Getchis, who initiated the healthcare for the homeless. Very small idea that now has quite national significance in terms of the breadth and scope of healthcare to the homeless. He was instrumental in launching Christ House, which was a focused residency for the homeless in the District of Columbia, and then subsequently developed Joseph's House, which is a focused residence for homeless men with HIV/AIDS. And our students have the opportunity to go and participate and engage with the men and understand some of the interconnections, obviously, with health and homelessness through the lens of HIV. I think at this point, what I'll mention to you is just some summary comments from the students who have finished with our service learning course. The themes that emerged, as I mentioned earlier, homelessness is not a sort of a monolithic group or block, but there's so much diversity and strength. Students used through another lens of resiliency formation, the idea that the men and women that they encountered truly had strengths and assets that gave them great potential to move outside of their environments in ways that they couldn't possibly imagine. And in fact, many of the men and women became teachers for them. So instead of the students feeling as if they were coming to them to teach them about health and sort of the disease and illness constructs that they would be encountering, they actually learned from the men and women so much about sort of human life and quality of life, even though there was such a chasm between the existences that they both had. Some of the students have since, as I said, gone on and extended their volunteer work as a requirement for Georgetown to serve in several of these communities. And my hope is that they will publish through what I have developed digital voice stories, and I think it was mentioned that you have some digital voice stories outside that will show how they have grown and matured through their interactions with the men and women. So just in closure, this is, I think, one sort of tool of learning that has, I think, tremendous potential in terms of reaching into students' lives and really crafting and developing themes for them that would give them a sensitivity, tools with which they proceed into other areas outside of health, such as health policy, to craft legislation that has the human potential to really make a change that's effective for all of us. Thank you.
And the third of our panelists, Dr. Barbara DePietro from the National Healthcare for the Homeless Council up in Baltimore, talking about the Affordable Care Act.
Good morning. There's a lot that I could talk about with the Affordable Care Act. I'll just do a quick 10-minute overview, particularly the aspects that are most important to those experiencing homelessness. I think it's particularly relevant lately as we just came off an election where healthcare was much debated and had some very different views espoused, and we kind of come back to the idea of, do people put themselves in the situation they're in, and what are the structural causes of some of those situations that we might take a broader look at. When we talk about health disparities and we talk about the different kinds of populations we see, I think there's a broad understanding, and unfortunately it's a misconception in the general public, that if you're poor, you qualify for Medicaid. But that's unfortunately not true. You have to be poor and you have to have some other condition. You have to be poor and be a child, poor and be pregnant, poor and be disabled, poor and possibly in some states to varying degrees be the parent of a child. But largely if you are low income and don't have a proven disability and you don't have dependent children, you don't qualify. And so what we're seeing here is some of the disparities in care. We've talked about healthcare for the homeless as one type of federally qualified health center, but we can see the disparities just in nationally. 62% of the 825,000 individuals we see every year are uninsured, and so that translates to approximately 500,000 people. And you can see the disparities just in regular community health centers that serve the otherwise low-income, underserved populations who tend to be more stable. And then again, you'll see then as those disparities when combined with the general public. And so when we think about the disproportionate impact of uninsurance on the homeless population, coupled with the rates of chronic disease, behavioral health, acute illnesses, risks of violence, injuries, all of the things that come along with being homeless. We have a saying in our clinics a lot of times, homelessness is hazardous to your health. And we see that in our health conditions, but again, those health conditions are exacerbated by not having access to health care. And so this is one of the things that we're tremendously excited about. The Affordable Care Act gives us a really good opportunity to make some inroads with access to health insurance, but as a key to accessing the health services that are needed to stabilize people's health. The idea is that if we can stabilize health, we can also stabilize some of the things that might be causing the homelessness to begin with. And so thinking about that again as a structural cause. So when we look at the law, we actually are seeing tremendous improvements on the way that the program currently runs. So not only do we get an expansion to the non-disabled population up to 138% of poverty. So for an individual, that translates to about $15,000 a year. And if you do a lot of economics or labor work, that translates to about minimum wage job at full time. So right there, if you work a minimum wage job at full time, you are right at the cutoff. So that has implications for how we do state-based exchanges and all the rest, which gets outside of my 10 minutes. But this is tremendous because 15 million people in the United States will be eligible for Medicaid based on this eligibility change. However, we know that eligibility doesn't always translate into enrollment. So those are some of the challenges that we have. Some of the other improvements to the include easier enrollment. You will no longer have paper documentation, which is tremendous. In fact, the law prohibits paper documentation except as a backup if it doesn't work. So there's electronic verification of your income and your identity, which is a great efficiency. We also see no permanent address is needed to apply for Medicaid starting in 2014, and you don't have to establish residency. So again, proving who you are, proving how much you make, especially if you don't make anything, proving where you live, bring in a lease, a utility bill, a rental agreement. All of these things are really hard for the population that we serve. Bringing in a birth certificate, social security card, any kind of photo ID. Again, these are the kinds of things that we replace over and over and over again in our clinics, but very, very difficult to hang on to. We also are seeing seamless coordinated eligibility. So again, across Medicaid and the state-based exchanges which will be developed, how is it that all of this ends up having to be seamless? So as the idea is that we're bringing people out of homelessness, we're getting people into employment, or we're getting them into disability benefits or some other structure where they're actually getting more stable. More stable generally means coming up out of 138% of poverty. I think we can agree that $15,000 a year is not living high on the hog. So if we're coming into an $8 an hour job and we've tipped up into $16,000 a year, does that mean discontinuation of life-saving medications, medications that enable us to hold that $8 an hour job? So again, it has to be seamless, it has to be coordinated. This is some of the challenges that states are looking at right now, but some of the things that are going to make our systems work better. Near real-time eligibility determinations. How many people here have done eligibility determination for Medicaid? Anybody? Okay, a couple of folks. So you know that you can put in an application, Department of Social Services or what have you, and 3 weeks later they have no idea what happened to the application you put in. You know, you call back, oh hey, I had to talk to so-and-so and so-and-so and the whole bit, I got a time state stamped and the whole bit. Yeah, nobody knows what happened. You know, you gotta redo it. 6 months later, you still have Mr. Smith who's waiting on Medicaid, which is the only ticket he's gonna have to be able to get chemotherapy or dialysis or medications or what have you. So again, this is the kind of thing where we're asking for improvements here. This is also a requirement for essential health benefits. A lot of work being done on, what's the threshold for what services are required. This includes mental health and behavioral health addictions care. It requires maternity care, hospitalization, ambulatory care, a whole range of services. But the outcome of the Supreme Court decision made that expansion to 138% optional for states. So what does that yield? We've been looking at a lot of red and blue maps in the last about year, right? This is a different kind of blue and red map, although you'll see it has correlations. So this is as of September, the red and pink states were the ones who were saying, no, we're thinking we're not going to do that. Blue states saying, yes, we think we're going to do that, and gray states saying, we're not quite sure, we're not going to commit. Now, no doubt, the election, now that that's passed, is going to change some of these conversations. But I think it's important that we take a look at, in particular, the states that are red are the states that have the highest rates of uninsurance in the country. So those are the ones that have the most to gain. And it's curious that this expansion to the newly eligible is 100% federally funded in the first couple of years, and it goes down to 90% federally funded after after it goes, I think it's at 2020 and beyond. So states get a really good deal. They pay 10% for those 15 million should all states ultimately determine that they're going to expand. So keeping an eye on how these state colors change and where states shake out, a lot of economic arguments to be made for expanding Medicaid. Now, if you've seen one Medicaid program in one state, you've seen one Medicaid program in one state. All state Medicaid programs are different, and this is part of what makes states really in the driver's seat of how effective the Affordable Care Act can be, particularly as it impacts those most vulnerable. You can see that there are a host of options here, beginning with, of course, whether they decide to expand. We haven't heard yet from HHS whether you can do incremental expansions and what that looks like, but we're hoping that states choose to go all the way. We can expand home and community-based services, more flexibility in how we do that. Health homes, there's a whole lot of work being done on how we do care coordination for chronically ill populations. A lot of work on accountable care organizations, how we're doing systems of care. Again, how are we coordinating care in an entire community across all systems? The breadth of essential health benefits. While we do have a list of 10 benefits that are required, states have got a lot of flexibility on what that looks like in reality. And then again, outreach and enrollment. Just because 15 million people are eligible doesn't mean 15 million people will enroll. Even if states decide that they're going to do this, they don't really have to do that kind of assertive, aggressive outreach we know is really required for a vulnerable population like homeless. And in fact, Congressional Budget Office is estimating that only 7 million people are going to enroll in the first year. So that brings us to managed care. Most of the expansion is assumed to be under a managed care model. Now there's managed care in a way that manages care, that really invests in how are we coordinating care and getting people the services that they need. Then there's managed care where every little thing you do requires an authorization, preferred providers, and you're not it. And a lot of contractual barriers that can be put in place. So again, we come back to what does managed care really look like? That will really be states to decide. So one of the things that I'm particularly interested in is the conversation we've been having about universal care, human rights that John talked about this morning. How is it that we're looking at the Affordable Care Act not as the panacea? There's still so much work to be done. Using Congressional Budget Office figures, we can see where we'd be on the blue line without the Affordable Care. We continue on at a pretty high rate of uninsurance, about 15–16%. Under the Affordable Care Act, of course, we can see dramatic declines, which is incredible. But when we look at what we're estimated, we still have 30 million people remaining uninsured 2 years after these expansions go into place. When we look at an analysis that was done by the Urban Institute, we see that in that uninsured, majority of people who are either Medicaid eligible but unenrolled, and that may be because of state decisions, or it may be just because what we know about take-up rates, and undocumented ineligible immigrants. So thinking about a remaining safety net, our problem with uninsurance doesn't go away. In fact, you can argue, with all that's said and done, all this argument about socialized healthcare, we've only fixed half of our problem. So just thinking about what that structure looks like. How many people here are policymakers or working in policy or want to be working in policy in the future? Okay, great. Issues to think about. These are the kind of things. How do we ensure outreach and enrollment? How do we make that really work? And that means boots on the ground. That means investing in people. That means more than a library kiosk. It means more than a billboard by the roadside. It means more than just an advertisement in the metro. It means real people under bridges, in alleyways, developing relationships. That costs money. We have to invest in that. Thinking about how we're dedicating resources for unenrolled. How do we fill gaps? Medicaid's not going to cover everything, particularly case management, housing, all of those support services, transportation, interpretation, health education, outreach in particular. These things aren't generally Medicaid funded and are certainly not required. So thinking about how we fill these gaps, how do we look at other safety net programs and what is their role under an expanded insurance paradigm? So Ryan White, health centers, rural health, maternal child health programs, block grants from Samsung. All of these things come together to form wraparound, for instance. And then thinking about innovations. Sorry, my voice is getting out. Focusing on innovations. So how do we cover services in housing, and how do we do assistance with housing? Medicaid actually does have a role for residential care. Pays for my grandmother in a nursing home, pays for the residential placement for the kid down the street. Medicaid does pay for housing. So when we think about, oh, Medicaid doesn't do residential, well, that's not quite true. Medicaid pays for a lot of beds in this country, and there's no reason why, particularly if we're looking at managed care and the sense of managing, and we're interested in economic arguments. $900 of rental assistance at a managed care can save $5,000 in hospitalizations. Thinking about that. Researchers. How many people in here are researchers? How many people in here are taking a course, enrolled in a class this semester? How many people here will be working on a master's thesis, PhD dissertation, something like this? How many people here write papers at some point? Okay, good, that's great. Things to think about, things to really look at. So how can we highlight housing as a clinical intervention? Thinking about that. We really see housing as healthcare. How do we quantify the changes, usually improvements, in people's health status? Decreases in cost, decreases in the service impacts of higher end service utilization in the community. How is it that we're really putting the numbers and the analysis behind that work to justify the kinds of decisions that states need in order to be able to go forward and say, yeah, we're going to pay for that? How is it that health insurance in and of itself doesn't really do much, right? But it is the key to being able to pay for and access health care in the current system that we have. So think about, how does health insurance, just the very access to health insurance, allow us to measure those changes? How can researchers give us that information? How is it that we can document the remaining gaps? Even when all of this goes into effect, we know, again, it's not going to be the solution fully. So what remains to be done? How do we quantify that? How do we identify that? How do we give those numbers to state policymakers who really need that, again, to be able to justify additional improvements? And then thinking about, what are successful models? What are the remaining barriers to care? Again, all of this stuff really needs to be documented by researchers. And then thinking about innovative practices. Highlight case studies, highlight what's working well. Is somebody doing something innovative or unusual? Let's get it out there. So again, thinking about the journal that's part of this forum here, lots of other places to put that out. And then social determinants of health, I think has been referenced a couple times, particularly to focus on poverty and housing. This is a little bit about the council. John had talked about it before. If you want to follow us on Twitter, that's where that is. Really proud of the health reform work that we're doing at this link here. We do offer individual memberships for those who are looking at technical assistance, particularly at states or in their healthcare organizations. Please let us know. And here's a little information about me. Here's also some good source material. It's really hard to get objective information anymore. Even when you turn on, the news and the television, it tends to be coming from some agenda. And let's try to think about real analysis, real research, real things that can inform the conversation and give us the talking points that we need when we're talking to our friends and our family and our colleagues, and putting that work into the policy making and the research that all of you will be doing in your work. So thank you very much.